Lecture 10.2, Atrial Arrhythmias. Irregularities in the atrial activity. Our first and probably most common atrial arrhythmia is premature atrial contraction, or PAC. And a lot of times they come not alone, so you might have PACs, plural. So isolated occur singularly, or we might get multiple PACs, which we'll talk about in a minute. So the rhythm is regular, right? Because the irregular, because the R waves are not coming at regular intervals. The P wave in the PAC right here is going to be premature and abnormal or completely hidden, like in this one right here. And the PR interval is going to be less than 0.2 seconds and less than 0.12 seconds for the QRS, so abnormal. So the PAC is just a contraction of the atria occurring early. So the beat comes before the next normal beat is due. So it's coming from somewhere outside of the SA node. Somewhere else in the atria is firing and causing the atria to contract sooner than the SA node would like them to. So the P wave is going to have a different shape than that of a P wave of a normal beat coming from the SA node. And then the QRS complex and the T wave are going to appear normal because it does conduct along the conduction pathway normally. So you have your normal rhythm going along here, normal P waves, and then all of a sudden you're getting an early QRS here before it would have come on its own. So these are actually really common and in healthy individuals. Definitely stimulants can increase the occurrence of them, so caffeine and tobacco. But if people are getting a lot of them frequently, it can lead to some serious atrial arrhythmias, and it could be indicative of structural heart disease. But we're talking, a very large amount of PACs in a very short period of time. So typically, they're quite benign and no need for treatment. Atrial tachycardia. So heart rate's 140 to 250, so higher than our sinus tach. Rhythm is still regular, and the P wave is usually very difficult to see because it's hidden in the QRS. So the PR interval is quite short, less than 0.2 seconds, and the QRS is going to be less than 0.12 seconds. So PAT is what we call paroxysmal atrial tachycardia. So paroxysmal just means that it comes and goes kind of abruptly, often without a known cause. So it's an abrupt episode of tachycardia that typically just starts and then stops suddenly. And the atrial rate is going to be 150 to 250 beats per minute. So we're getting into a faster zone there than your typical sinus tach. And it typically only lasts a few seconds, and then the heart rate returns to normal. And of course the EKG cycles are going to be very close together because they're coming so fast. And then here you can see that the PAT broke and it returned to a nice normal rhythm. PAT is a very common rhythm disorder, and it can often occur in young healthy patients, especially young adults that have otherwise normal hearts. But it can also occur in patients with heart disease as well. And it's harmless, it's benign, but it can often cause quite severe symptoms during the episodes. So there are treatments that can help the patients who are suffering from those symptoms. So those are sudden pounding or fluttering in the chest, feeling lightheaded or dizzy, getting very breathless or having difficulty breathing, and then having a very acute and severe feeling of apprehension or impending doom is often a symptom that patients will describe. And then they could actually pass out and experience a syncopal episode. So along those same lines is AVNRT, which is atrial ventricular nodal reentry tachycardia, where basically, let's see if I have a picture here. No. Basically, it's similar to PAT, but the conduction pathway kind of gets stuck in a circular loop in the atrium right above the AV node. That's why it's called a reentry tachycardia. Similar, same treatment for the PAT if the patients are symptomatic. Okay, atrial flutter. So this is a very fast heart rate, 220 to 430 in the atrium, and then typically it can be up to 300 in the ventricles. The rhythm is, it can be, actually it's kind of regular. And the P waves give a very sawtooth appearance. This is a typical A flutter right here where it looks like sawtooth, like a saw. You're not going to have a PR interval per se because there's usually so many P waves for each R wave. So it's pretty much impossible to calculate. And then the QRS is going to be less than 0.12 seconds. So basically, this is when the atria begin beating in a rapid and regular fluttering pattern. Quite fast, right? So you're going to have more than one P wave before each QRS complex, sometimes up to 8 P waves, which creates this sawtooth appearance between the QRS complexes. The QRS complexes are going to be normal, except for the fact that the T wave is usually lost within all those P waves. And then the ventricular rate can vary depending on how many of these, how well these P waves in the atria are actually conducting down the pathway into the ventricles, right? So atrial flutter can occur in patients who have mitral valve disease, CAD, coronary artery disease, chronic lung disease, hyperthyroidism can cause it, pulmonary embolism, alcohol and stimulants, diet, pills, cold medicines, caffeine, etc. The most common place that I see it is perioperatively, so either right before or right after surgery. Definitely open heart surgery, that's very common, but it's actually not unusual for people to come up with an A flutter on the monitor, even if they're just having, knee surgery or hand surgery or something too. So similar to A flutter is atrial fibrillation, or AFib. So in AFib, it's extremely irregular, the fibrillation. So that's the main difference between flutter and fib. Is flutter actually is quite regular, but fibrillating waves between the heartbeats are completely irregular and erratic. So the atria is actually quivering in a fluttering motion rather than getting a complete contraction and squeeze. And so it's giving, incomplete, irregular contractions. The rate can be quite high if untreated, 350 to 500 beats per minute. And it's very irregular and erratic. The P waves have no distinct pattern or shape because it's so rapid that they're just not contracting completely. The QRS complexes are normal because once that conduction actually makes it down into the ventricles are able to contract normally, but they're just not going to be regular and they're not going to have a definite pattern. So the ventricular rate could be rapid, or it could actually be normal, if the intrinsic rate of the AV node and the Purkinje fibers are able to take over. They can regulate the ventricular heart rate. So as you see here, this is actually fairly, normal. It's not fast. It's not tachycardic here. But the P waves are really irregular, and there's no set amount in between the QRS complexes like we saw in the flutter. So AFib is actually a really common arrhythmia that can occur in otherwise healthy individuals. It's often idiopathic, which means we don't actually know exactly what causes it all the time, right? But it is when there's, some sort of damage to some of the pacemaker cells in the atria. Uncontrolled hypertension can cause it. So we do know that there are a few things that, can increase a patient's risk for AFib. Heart disease, pulmonary hypertension. It's not uncommon to have perioperatively, kind of like a flutter. Congenital heart disease, rheumatic heart disease with mitral valve damage, CAD, and then other mitral valve diseases. And then stress, excessive alcohol consumption, and I don't have it on here actually, but a really strong indicator is obstructive sleep apnea, or OSA. So a patient who is untreated and having severe apnea can also can kind of cause their heart to go into AFib. So AFib comes with a high risk of stroke, because as the blood's kind of hanging out in the atriums, because they're not contracting and squeezing completely and pushing that blood down to the ventricles, the blood actually pools up and can form a clot. So there's actually this very small area over off of the left atrium that is prone to blood pooling and clotting in there. So when they finally do get pushed through, then they can, get pushed out to the rest of the body and block an artery, and cause severe complications such as stroke or a deep vein thrombosis, also if it makes its way into a vein. Also, if it's uncontrolled, the heart rates are extremely fast, chronically, then that can cause heart failure. Definitely, people can feel very fatigued. They often feel short of breath, and then it can lead to additional rhythm problems, and it can lead to sudden cardiac arrest if left untreated with a high heart rate for a long time. So typically, let's see if we have the treatment here. No. So typically we would treat a patient with anticoagulation to, quote, thin the blood, unquote, to keep them protected from a stroke or a clot. And then you treat the fast heart rate, usually with anti-arrhythmic medications or a beta blocker, something to slow down the heart rate and keep it controlled. And if people are asymptomatic from AFib, which is not unusual, they can actually live, quite a long time with atrial fibrillation, as long as they are protected against stroke with an anticoagulation therapy, and then as long as their heart rates are well controlled and are not going fast chronically, which causes a lot of stress on the heart. So just to look again, because people often get confused between atrial flutter and atrial fibrillation. For flutter, the impulses are traveling in a circular course in the atria. So it's rapid with regular waves. And then with AFib, the impulses are totally chaotic and random. And so the waves are very irregular. Okay, so atrial ventricular block, or AV block, often known as a heart block. There's a lot of different kinds of heart block, so it's kind of a general term, but basically it just means that there's a portion of the conduction system that is slowing or disrupting the normal conduction through the heart. So there's 3 degrees. First degree is the least severe, and it's often no symptoms, and it can be seen in well-trained athletes, and it typically comes along with a prolonged PR interval, so greater than 0.2 seconds. Second degree AV heart block is when the heart can actually skip beats, so the beat is getting stuck at the AV node and not making its way down to the ventricles for them to contract. The PR interval tends to lengthen in each interval. Kind of, if you were to look at these ones before the QRS complex disappears, or the dropped QRS, you'll notice that the PR interval is getting a little bit longer, and then it just doesn't make it at all. And then it might go back to normal right after the dropped QRS. So this can often be treated with a pacemaker to help kickstart the heart wherever it's getting blocked, and then prevent it from becoming worse, or prevent the patient from actually fainting and hurting themselves or somebody else. So third degree, or complete heart block, is when the atria and the ventricles basically are beating just completely independently from each other, and there's no relationship between the P waves and the QRS complexes like there should be. So it severely limits the heart's ability to adequately pump blood out to the body, and so this is typically a quite emergent situation and requires very quick implantation of a permanent pacemaker. So the P waves and QRS complexes are totally independent of each other, but they can be regular. But you have a P wave here with no QRS, another one here. Okay, so that's the end of lesson 10.2.